Our next speaker is joining us remotely, Dr. Holger Schunemann from McMaster University in Canada. Can value of information analysis help inform research priorities? Dr. Schunemann.
Thank you very much for having me today. Let me just make sure that I share my screen here. And let me please confirm that you can see my screen.
Could the sound be a little louder, please?
Let me perhaps just close my video then. Make it larger.
We can hear you, but to the extent if you could speak a little louder, that would be great.
Yes, I will do that. I apologize for that, but I will stop sharing my screen and I think my video, and believe that will deal with the issue. Is that better?
Yes.
Yes, thank you.
Okay. Thank you. Once again, thank you very much for allowing me to contribute today. I'm sorry that I had to join you remotely. Probably a wise choice because of a storm that is arriving and would have probably led to cancellations of flights. Once again, it's an honor to be able to contribute to this effort, which is a nice follow-up from work that we've done for the IOM report at that time called IOM on Trustworthy Guidelines. My presentation complements Dr. Mercer's presentation, which I enjoyed. It was the only one that I could participate or listen to this morning, and I will be speaking about approaches to getting the research question right for systematic reviews and updating of subsequent evidence reviews, which is the topic that I was given. As I said, I'm joining you remotely, and Hamilton McMaster University is essentially located here, Lake Ontario, and it's the department that I chair is simply the birthplace of evidence-based medicine and problem-based learning. I represent a number of groups today, including Cochrane Canada, for which I'm the director. These are my disclosures. I will be mentioning a guideline from the World Allergy Organization, and we've received funding for various reviews that we've done for the World Allergy Organization, and I'm obliged to mention that by my institution. Today's presentation, as I said, will focus on these two key issues, but I'd like to be a little bit broader than just thinking about intervention effects. So in particular, I will focus on which criteria should be considered in addressing the guideline question correctly, and then, as indicated in the title, speak about work that we've done with the Cochrane collaboration primarily, but also with some institutions such as ARC or organizations such as ARC, on maintaining and updating systematic reviews. And particularly, I will focus on evidence to decision frameworks. And as I said, this will be a complement to the prior presentation. One example that I will use is an example from a World Allergy Organization guideline, which dealt with utilizing prebiotic supplements for allergic disease prevention, GLAP-P guidelines, and I will frequently show screenshots of papers very quickly so that they can be deposited as possibly background reading. But one of the questions that we addressed in that particular guideline was whether or not prebiotics should be used in healthy infants. And I'm sure that you've reviewed the formulation of healthcare questions previously, but this is just a lead into, as I said, thinking about questions in a general way. So the first thing that we will notice is that there is no comparison to a better question, and the way that we phrase it in detail in this particular guideline is should prebiotics versus no prebiotics be used in infants. And obviously, the first thing that comes to mind is that will depend on the outcomes that are affected. both health outcomes as well as other outcomes. And in the work that we've done with these various organizations that I mentioned and represent, we've developed different approaches to identifying or prioritizing outcomes. And the main reason for that is obviously that not everything that is measured is important, and not everything that is important is measured when we are answering these type of healthcare questions, as we also saw in the previous presentation. So typically, we start with an enormously long list of outcomes. This is not from a nutrition guideline, it's not from that particular example that I just presented, but for any guideline that we are producing, and we've been involved in obviously many guidelines, typically the team that is involved, the guideline panel that is involved, starts with considering a long list of potential health outcomes that are affected. We've once again utilized and validated ways of identifying the outcomes that are then relevant, primarily through Delphi type of methods that I will not go into detail here, but would be happy to explain in the question section. So we prioritize, just as one part of these methods, we prioritize outcomes by rating their importance for the population that is affected by that particular outcome. We use two types of scales, for instance, 1 to 9 scales, or one method is using 1 to 9 scales, typical visual analog scales that help us identify whether or not outcomes should be considered in a guideline development process. So for these particular allergy guidelines that I mentioned, we would have utilized these this approach, where a high rating indicates that the outcome is considered important for decision making, in other words, for formulating a recommendation, and a low rating, a 1 rating, would mean that the information may be available, but it's not, it's of limited or no importance for decision making. And utilizing these exercises, we then identify what, first of all, is the relevant critical question that identifies, that includes outcomes, that has a number of implications. It has implications for the review conduct, the systematic review conduct, because a review group wouldn't be searching or looking for information that is not important for decision making. It limits the amount of work that is required and necessary, and it focuses on what is really critical for decision making. So a typical question, or the full question for that particular guideline that I mentioned, would have been, in infants, what is the impact of using prebiotics compared with not using prebiotics on the outcomes that the guideline panel felt was important for decision making. The rating that I showed you, the 1 to 9 rating, is one method to arrive at this. Obviously, one can use population utilities or values and preferences to arrive at these outcomes as well. But once again, this is to highlight one approach to how a guideline panel would arrive at the relevant outcomes. And in this particular case, eczema, allergic rhinitis, asthma, food allergy, adverse events, and nutritional status were rated as important or critical for decision making. And we would end up with a typical peak or population intervention comparator and outcome question. We utilize in our approach, once again, this complements the previous presentation, we utilize what we call summary of findings tables to present the key information from the systematic review to decision makers, both also in this case in quantitative ways as well as in qualitative ways or semi-quantitative ways, similar to what we saw before, by focusing on the outcomes, once again, that are important or critical for decision making. These summary of findings tables typically include information about the outcome that is, once again, important or critical, a relative estimate of the effect, absolute estimates of the effect, and a quality or certainty rating that is similar to what was presented for the U.S. Services Preventive Task Force. We typically use, and Cochrane uses, the GRADE approach to rating the certainty or quality in the evidence. And that is based on the criteria, similar criteria that we just heard about in the prior presentation. I will not focus my presentation on these criteria. They are fairly standard and widely used by over 100 organizations internationally. So I'm showing this summary of findings table with another purpose, and that purpose is that we believe that the work, or we can demonstrate that the work is facilitated by having this summary of findings table, the information that at the end is presented to the guideline panel in your mind as a developer of a systematic review at the very beginning. So we start our efforts often with blank summary of findings table. What is the information that the decision maker, those who formulate the recommendations, need to have at their hands when they actually meet at the guideline panel? I'm moving on. So the recommendation in that particular guideline would have read, the World Allergy Organization guideline panel suggests prebiotic supplementation and not exclusively breastfed infants. So here you already learn about the subpopulation, both at high and low risk for developing allergy, and it's considered a conditional recommendation based on low certainty of the evidence. Conditions, for instance, would be a result of underlying values and preferences that a particular population may have for the particular outcome. So if a relatively high value is placed on avoiding additional costs, this recommendation might not be implemented, and if there is a high value placed on the smaller chance of avoiding allergies, this recommendation might be followed by a practitioner in practice. Now, obviously, there are more factors or criteria than values and preferences that lead to either a strong or conditional recommendation or a recommendation and decision at all. And so what we have spent a great deal of time on long project with Cochrane and the great working group, other collaborators, is to make sure that our questions, that we develop frameworks so that our questions are being considered in the context of the actual recommendation that follows. And the criteria that are being considered are listed here. So how important is the problem for the population? How substantial are the desirable anticipated health effects, the undesirable anticipated effects? What is the certainty and the evidence of these effects? Values and preferences, is there important variability? Does the balance then, when considering the values and preferences, the importance of the outcomes, does the balance between the desirable and undesirable effects favor the option or the comparison? How large are the resources that are required? What is the effect on equity? Is it acceptable and feasible to implement? And what that tells us is that our typical healthcare question that focuses on intervention is only a small piece of the puzzle. The population, the underlying population, if we're, for instance, dealing with a population that suffers from certain nutrition deficits, are we certain about our diagnosis? And we can conduct systematic reviews that appropriately identify this population. What is the baseline risk? We can conduct systematic reviews, and this is what I mentioned earlier. I want to broaden the perspective a little bit. We can conduct systematic reviews about the baseline exposures, which populations are at risk. We can conduct systematic reviews about the importance of the outcome, so about values and preferences. We obviously need the systematic reviews for the interventions or exposures, which is particularly important in the nutrition field. So in other words, I've been asked to talk about systematic reviews and updating and the context of systematic reviews in terms of getting the question right. We strongly believe that systematic reviews can inform all of these aspects. And this is from a Guideline International Network Guidance for Guideline Development project. Essentially what I'm talking about is that we are summarizing, or our task is to appropriately summarize in a trustworthy way the evidence, all of the evidence that is important for making a decision. This is obviously dealing with the intervention effects and test accuracy issues, but it also deals with issues around values and preferences, baseline risk, and so on, equity, feasibility, and accessibility, which we're doing with many guideline panels. Let me move on and speak a little bit more about these decision criteria. So after having formulated, we use software tools to both to enhance reproducibility as well as enable sharing across different group members or guideline panel members. In this case, we use a tool that is called GradePro. This is the question that had informed the particular recommendation that I showed you about using prebiotics versus not using prebiotics. As a panel, we would work through individual criteria, the individual criteria after the evidence review that inform this decision. And these decision criteria, these evidence to decision frameworks, are modifiable or are adjusted or used in the context of the decision-making context. So if feasibility is not something that a guideline panel would have to consider, then that feasibility icon here would be unclicked, and feasibility would not be an issue that a guideline panel would consider under those circumstances. Cost may be another example for, in particular, professional society guidelines. An adaptable framework for making decisions. And this is just a reference, papers in the BMJ and the Journal of Clinical Epidemiology, Implementation Science, and Lancet. This is just for later review. So these evidence to decision frameworks, these criteria that I described, help guideline panels move from evidence to a recommendation by informing judgments about the benefits and harms of an intervention, by making sure that each of the important factors or criteria that are relevant for making a decision are considered, by providing a concise summary, such as a summary of findings table to inform research judgment, and by helping to structure the discussion of a guideline panel and identify reasons for disagreement. And more importantly, in reference to Dr. Lau's comment, they help also to make decisions transparent, but they help with sharing information and sharing judgments that were made by certain guideline panels based on systematic reviews, and help with updating systematic reviews, which I will show in a second. So an ETD framework would look as follows. The panel would work through individual criteria on which a recommendation is based, would inform or describe the reasons for judgments that are made. So, for instance, how large are the desirable effects? That is based on the research evidence from systematic reviews and additional considerations that may inform or explain each judgment. So, for this particular example, a summary of findings table would be shown to the panel, and the panel would make a judgment based on the information, the systematic review that has been conducted, whether or not the desirable health effects are trivial, small, moderate, or large. This, once again, increases transparency and leads to judgments that are recorded and can be revised when a guideline is updated based on new information. It serves as a record as well. Just to show this relatively quickly, a guideline panel would work through all of these individual criteria for decision-making and make judgments that can then be reviewed by other groups or stakeholders and utilized for further updates. At the end, when a guideline panel has worked through the individual criteria, we show a graphical display that indicates whether or not a recommendation should be made against or in favor of an intervention, and whether or not this recommendation should be strong. So, for instance, if there are moderate or large desirable effects and small undesirable effects, it would favor a recommendation for prebiotics. And all of these individual judgments would be described in order for a guideline panel to then arrive at a recommendation. In this case, it was a conditional recommendation in favor, with a justification and potential subgroup considerations, research priorities, and so on. So these evidence to decision frameworks provide a reason for the recommendation, the direction, strength, and certainty. They allow adoption, adaptation, and new development of recommendations. The key criteria are how big is the problem locally, how direct is the evidence, how does it impact on these other criteria, resources, equity, acceptability, and feasibility. They allow maintaining and updating evidence that's organized properly. Okay. This is just a very quick reference to a recent work by the Economist, the intelligence unit, on nutritional guidelines for sustainable healthcare policies. To break up this presentation, worthwhile reference. I will conclude my presentation by briefly speaking about updating the evidence. This is from the article that I described in the BMJ, an effort by the Cochrane collaboration and various other groups, including members of ARC and professional societies in the US. And it dealt with when to update intervention reviews, primarily intervention reviews. This guidance, however, is not necessarily context-specific. So it may not, the guidance contained in this manuscript may not be focusing on guidelines where questions are driven by stakeholders that may be quite different from organizations that conduct systematic reviews without identifying the priorities or without having a specific target for which the systematic reviews would be used. So that is a word of caution here. This is just to show you that different organizations use different approaches. So in this paper, we highlight the ARC approach as well as the Cochrane approach, which once again is primarily, so far, primarily author-driven, although this is changing in the context of the of reaching out to more stakeholders such as guideline developers. And I wanted to highlight just some key aspects of this paper. So for instance, what would drive an update of a systematic review? So one approach is to say, whenever there is a certainty of the evidence that is not high, in other words, doesn't achieve the highest rating, an update may be required when the systematic review is utilized for a guidelines panel. And that would be based primarily on certainty ratings, once again, these established methods. We reviewed other methods, such as routine surveillance of the literature through PubMed or Medline searches. There are two methods listed here, the Ottawa method and the RAND method. The RAND method, for instance, would be based on a search of 5 major journals to identify new studies. And then there are statistical prediction tools similar to what we heard about. So, for instance, a value of information analysis, which builds on statistical prediction tools, or information that, for instance, has to do with whether or not new information leads to quantitatively different results. And then finally, just to give you a practical example, one of the questions that we would be asking is, will new studies, information, or data change the findings of a systematic review? If they do, then we should obviously update, and I'll give you a practical example from a guideline that we produced recently. Here's the reference for that, and once again for the repository. The example is as follows in response to Dr. Lau's question of information sharing. We updated a guideline that initially was produced, a systematic review was produced by NICE in the UK, the National Institute for Health and Care Excellence. We were in contact with the original systematic review authors and utilized and obtained permission to utilize their data. That particular guideline panel, it's not a nutrition example, I apologize for it, but it's such a good example that I wanted to show it. That particular example dealt with 2 different techniques to treat acute heart attacks, myocardial infarction. And that particular systematic review had identified only